Overall, in our patient population that was generally fairly heavily pretreated, everybody had prior anti-estrogen therapy as per the Elacestrant label. Over half of patients had received fulvestrant. Most patients had been treated with a prior CDK4/6 inhibitor. Over 40% of patients had one or more lines of chemotherapy. We found that the time to next treatment on elacestrant monotherapy was 6.4 months, and the time to treatment discontinuation on elacestrant therapy was 4.6 months. And we used time to next treatment and time to treatment discontinuation here as surrogate outcomes for progression-free survival. We looked at elacestrant use across lines of therapy, and we found that the efficacy of elacestrant monotherapy was fairly similar, whether it was being given as second line, third line, or even fourth or later line treatment. We looked at patients specifically that had no prior fulvestrant versus those that had previously received fulvestrant, and we found a trend towards better outcomes on elacestrant if patients had not received prior fulvestrant, although that finding was not statistically significant. We also looked at specific ESR1 mutant alleles and found that elacestrant treatment outcomes were fairly similar regardless of the ESR1 mutant alleles that were detected, whether it was Y537S or D53AG or other ESR1 alleles, that the outcomes on therapy were fairly consistent across those subgroups. We did find that patients with a high burden of ESR1 mutant polyclonality, defined by patients that had 4 or more concurrent ESR1 mutations detected at baseline, actually did worse on elacestrant monotherapy compared to patients that had just a single ESR1 mutation detected at baseline.